So this is a slice through the pelvis. This is the prostate in the middle here. At the front, this white area is the beginning of the bladder, and at the back, the black, and this area here is the rectum. So if we go up or down, there we go. This is a slice taken a little bit higher up through the pelvis. I'm hoping the screen has moved, has it? And you've got a bit more of the bladder visible now. You've got more white in a sort of a horseshoe shape. That's the very top of the prostate here. And these are the seminal vesicles at the back. So these blobby white things at the back here are the seminal vesicles. And you can see that part of the seminal vesicles are quite dark here in the central part. And that's because in this particular case, the prostate cancer is extending up and into the base of the seminal vesicles. This is a picture taken from the external beam radiotherapy planning software. So this is sort of conventional treatment, not brachytherapy. I'm just going to show this to give you some comparisons. And what you can see in the middle there, hopefully, are a variety of different coloured lines. And this is what we as the clinical oncology team do. We come along and we draw on the bit that we think needs to have treatment. So we've drawn some orange lines here in the centre, and then those orange lines are grown into these purple and pink lines, which become what we call the planning target volume. So the safety margin around the bit that we want to treat. Now, the reason for that is that we're concerned about the movement of the prostate every day, and we want to make sure we're treating any microscopic disease outside the prostate as well. So you give a safety margin. But the plan you end up with external beam radiotherapy involves beams coming in from multiple different directions. So you might have a beam from the front, a couple angled in from the front, a couple from the sides. And inevitably, the radiation therefore will go through a lot of normal structures as well. And that's part of the benefit and the gains that you get from brachytherapy, because in brachytherapy, you're sticking the radioactive straight into the prostate. You're not having to come through the skin, through the muscle. I mean, you can see on this image how much there is to get through, from the skin surface, through the fat here, through the muscle, through the bone, all the way down to the center, to the prostate. And this particular image is in the lower part of the pelvis where there's no bowel or bladder visible. So on to brachytherapy. Let's talk through the procedure of what we do and show you some graphic images that'll make your eyes water at 7 o'clock in the evening. Hopefully you got your gin and tonic at the ready. So there's a bit of preparation the day before the procedure is done, and that's basically to clear the bowel out as much as possible, because the planning of the procedure is done with an ultrasound probe up the back passage, pointing at the prostate gland. So we need the bowel to be completely empty. So you have a day off your food, just fluids, and a whole bunch of bowel medication to clear people out completely. And then on the morning of the treatment, people come to the admissions unit first thing in the morning. They meet myself or my counterpart, Dr. Nick Pota, who does the prostate brachytherapy with me. He and I do it for the patients in Sussex. And then we do the consent process and you meet the anaesthetist. And then you go around to the theatre room and go to sleep. So they have a spinal anaesthetic to put them to sleep, just like an epidural. And then they have a light general anaesthetic as well, because it's a relatively quick procedure, about 45 minutes procedure. So we don't want a deep anaesthetic because we want them to wake up and recover pretty quickly. And then when people are asleep, they get put into this undignified position where your legs are up and out the way into some stirrups. And the genitalia, the testicles and penis are taped up and out of the way. So you can reveal what's called the perineum, that area of skin between the prostate, between the testicles and the back passage. And over that perineum is placed a template with an ultrasound probe going into the back passage. That's what the template looks like. It's got, as you can see, numbers and letters as a grid system. And the images that we see on the ultrasound screen then tell us where we need to put the needles. And I enjoy saying this to the medical students as they can relate to this, but you basically then play battleships, because you've got an ultrasound image of the prostate in front of you and you've got a grid and you say C3 or B2 or A5. And we work together with the radiographers and the physicists in the theatre, and we put the needles into the prostate. This is a picture actually talking about the implant of seeds in this particular case, and this bottom right image is showing you some little black blobs, which are the radioactive seeds, which are connected by a little thread. That's not the procedure for the high dose rate brachytherapy, where what we're putting in are blind ending plastic tubes. And then they stay in that template, this template that you saw here, and they're locked into place by a clever locking device. The patient, then that template there is then stitched to the perineum, so that the patient then wakes up with about 20 plastic tubes through that template, stitched onto the perineum, and they wake up with a catheter in their bladder as well. So that's another image of how it's given with a bit more anatomy. So you've got the ultrasound probe there, you've got the template grid here on the skin, and you're putting in the implant catheters, as they call them here, or plastic tubes, straight through the skin and the base of the shaft of the penis here and into the prostate. In fact, the needles go through the prostate and out the other side a lot of the time into the bladder. And that's to make sure that we've got a safety margin at the end there, so that if the tubes then move during the day, there's a bit of extra safety area to make sure we cover the whole region. Then we do some planning scans in exactly the same way as we did when we were talking about external beam radiotherapy. So this is a CT scan now of the patient's prostate. And on this occasion, compared to the image I showed you before, you can see lots of white dots all the way through the prostate here. And these are the catheters, with a metal CT marker placed within the catheter. And you can see that they're nicely distributed, with about 4 at the front there, 3 at the side, another 2 or 3 at the side there, about 3 or 4 at the back, and about 4 in the middle. This area here at the front, which has been outlined and contoured, is the catheter. And the catheter will therefore give us an idea of where the urethra is. And the key organ that's going to get side effects and problems with brachytherapy is the urethra, is the pipe going through the prostate. So we need to know exactly where that is, but fortunately the catheter shows up on the CT scan, so we can identify that very, very easily. These are some other images just showing you the layout in the anatomy. So this is an image taken straight through the body, as if you were cutting down through the patient straight down. And you can see the bladder here. You can see the tubes, or at least some of them, poking straight up and into the bladder. Lower down, you can see the dotted coloured lines, which are the outlines covering the prostate that we're going to treat. And then finally, this is an image as if you were doing a different orientated slice straight down the middle of someone, splitting them into the right and left rather than front and back. So splitting the patient right and left, this is an image straight through their centre, because you can see the spine at the back here. And you can see the rectum, which is marked at the back, and the bowel that goes up behind. And again, you can see all the tubes coming in through the skin into the prostate gland. You can also see quite nicely on this image the catheter, or at least some of it. So the catheter does this U-bend here, where it's coming in from the penis. It's going through the urethra, round up through the prostate and into the bladder. And then decency protected with a little blob over the relevant region here on the final image. So this is what it looks like when the patient finally gets to the cancer centre for the brachytherapy treatment. So they've woken up from their anaesthetic. They've had a CT scan and an MRI scan. And myself and the physics team have done all the voluming and planning together. So I draw on the area that needs treatment, and I draw on the urethra and the rectum to say that doesn't need treatment, thanks very much. And then the physics team come up with a plan about where the radioactive source needs to loiter in the prostate, in those plastic tubes, and for how long. And then when that plan is ready, the patient comes into the protected room, and these plastic cables here are connected to the tubes that were hanging out of the perineum, the area down in the just behind the genitalia. And the tubes, these cables here, are connected to a lead-lined box, and inside there is the radioactive source. And the radioactive source is on the end of a long cable, and that long cable then forces its way down through each of the cables into the plastic tube in the prostate, one after the other. And each time it goes into the prostate, it then loiters for a few seconds in different positions to emit the radiation in as accurate a way as possible. to deliver the dose of radiation deliberately straight into the prostate gland, but not into the bladder or to the back passage or anything else. And therefore you're avoiding an awful lot of normal structures by doing it this way. Once that procedure is finished, so the actual process of delivering the radiation with that wire going in and out takes about 20 minutes, half an hour maybe. So that's actually the shortest part of the day, but we're talking now about mid-afternoon, late afternoon, by the time this the patient gets around to having this part of the treatment, after having come in at sort of 7:30 in the morning. So it's a long old day for both patient and staff. And then once that treatment is finished, the tubes can come out of the prostate. So about 15 or 20 tubes are pulled unceremoniously out of the prostate gland with a bit of gas and air, a bit of Entonox and painkillers as required, because that can be probably the most uncomfortable part of the day, in fact, because the anesthetic is starting to wear off, but it only lasts about 2 or 3 seconds. So most people squirm briefly and then relax because everything's done and the tubes are out. The urinary catheter is still in place, and at that point, when the plastic tubes are out of the prostate, we can see whether we've caused much in the way of bleeding into the bladder. And the urine, because the urine will change colour, and depending on whether it goes a light rosé or a dark claret or remains urine coloured, then dictates to us what we need to do, as in whether we can leave the catheter in for a bit and irrigate the patient. In other words, force some saline into the bladder to wash out any blood or clots, or whether in fact we can take the catheter straight out. The key thing there also is that once you've taken a catheter out, what you want to happen is for the patient to be able to wee themselves successfully. And they need to wee a couple of times to prove that the pipe is clear and that there's no clots blocking the way, so that then hopefully we can send the patient home. So the aim and the hope is that it's a day case treatment. We have had a number of people who stay in, but more recently, actually, the vast majority have gone home. That's partly probably also because we're just doing 1 case per week now. We're doing it every week as opposed to fortnightly, but we're doing 1 case each time. So, and it happens on a Thursday. So tomorrow morning I'll be in theatre sharpening the plastic tubes and getting ready for the next case. And as I say, over the last 3 to 4 months, every patient has gone home the same day. The key side effects are that the area which we've punctured with 15 or 20 tubes is inevitably going to become a bit battered and bruised, and it can become quite dark and discoloured due to all the little punctures that we cause. The prostate becomes a bit swollen because, as you'd expect when you shove a bunch of tubes into it, and if it swells, it can swell outwards, but it can also swell inwards. And by swelling inwards, it can narrow the pipe a little bit. And by narrowing the pipe, it can then affect weeing. It can then make people have a poorer stream and not go as easily, and sometimes go a bit more frequently at night. Now, that narrowing of the pipe is the cause of the blockage as well, if they can't wee successfully, excuse me, and have to have the catheter back in. About 2 weeks after the brachytherapy is done is when people get their external beam radiotherapy treatment. So the vast majority of patients having high dose rate brachytherapy are having it in combination with external beam. So in other words, it's given as a boost to try and increase the dose to the prostate where the vast majority of the tumour is and the key components of the cancer are. But they also need the safety margin of treating around the outside the prostate, and possibly sometimes treating the pelvic lymph nodes as well, which is what happens with the external beam radiotherapy. The external beam radiotherapy usually starts a couple of weeks later and is somewhere between 3 and 4.5 weeks long. And then there are slightly different side effects, but there's a bit of an overlap with the external beam radiotherapy. So that includes things like a bit of loose bowels, a bit of diarrhea, and possibly some aggravation of the urinary symptoms again. So that, I think, was the end of the snapshot slideshow of the brachytherapy procedure. I have got 2 other presentations which we could or don't have to do. I'm going to be partly guided by Roger here, and I can see him on my little screen to the side of what I'm displaying, so you can nod or shake your head. So we could do some questions on the brachy, or I could do another quick presentation if that's helpful. Or do you want to unmute, Roger, and let me know what you think?
Yeah, it might be worth doing some quick questions on the brachy before going on to another.
Yeah, if I stop sharing and then I go to participants, then I can see if people put their hand up, I think. So, and you have to electronically put your hand up because I can't see you in my screen because we've got too many people for the screen. And if people don't know how to do that, you go to the bottom of the screen, there's a little icon that says participants, which we're up to 55 now, I think. Mm-hmm. And you click on that, and on the bottom right, you'll see a column of names, and on the bottom right, you click raise hand. So Ray has raised his hand. Now, Ray, you're probably muted, so you'll also need to unmute yourself, and then you can speak.
Oh yeah, interesting presentation you did. They're very informative. One question I have is, what happens with the radioactive material? Is it actually left inside the prostate, or is there no material left there at all?
No, nothing at all. So it's a blind ending plastic tube, and the radioactive wire, which is attached to a normal wire, is pushed into the prostate, to the tube, and then it comes straight back out again, and then it goes in the next tube, and then it comes out again, and then it goes in the next tube. And once it's done all of them, the wire goes straight back into that lead-lined box again, and is sealed away, so it's completely safe. And that's when the radiographers can come back in, and there's no radioactivity in the room at all. That source needs changing every few months because its radiation decays and you lose the radioactive, you lose the activity of the source. So every 3 or 4 months we have it changed, and then that can affect the time that it takes for each patient to receive their dose. But no, it disappears again. Nothing's left in the patient.
So you're not walking around partly radioactive for...
No, so that's the difference from the radioactive seeds, in fact. So the implant seeds do make people very slightly radioactive for a bit. The radioactivity falls off extremely quickly with the seeds. So by the time you get to the skin surface, the dose is very, very tiny. But patients who do have seeds put in are given certain bits of advice about avoiding pregnant mothers and babies and that kind of thing for a bit of time. Not very long, but they are a little bit radioactive for a while.
Thank you.
Okay, thank you. We've got Ron Linkins.
Yes, by coincidence, I am due to have high-dose brachytherapy on Monday and Tuesday next week up at Mount Vernon Hospital.
Okay.
And I'm told that he'll be doing a session on the Monday and also one on the Tuesday.
Okay.
So I'll have to sleep with the big plastic sort of thing stitched to me overnight. So
yeah. Okay. Yeah.
I'm comfortable. But the history is I had external beam radiotherapy back in 2013.
Yeah. So this is a salvage treatment, an attempt to get rid of it.
Salvage radiotherapy.
Yeah.
I don't know how common that is, or how common it is to have two lots.
Are you part of a trial, or is this a?
No. I've been referred by my oncologist down here up to Mount Vernon under Professor Hoskin up there.
So I don't know whether he's doing it. Is this Peter? No, Peter Hoskin's not there anymore. Is it Roberto Alonzi and Peter Osler and that team?
No, Peter Hoskin, Professor Peter Hoskin.
Yeah. Oh, I thought he'd moved to Manchester. He's clearly.
No, he's at Mount Vernon.
Still at Mount Vernon. Okay.
Yeah.
So he's doing a prospective data collection of patients who are getting salvage brachytherapy after they've got recurrence following previous external beam radiotherapy, which is exactly what you're getting. That what we call fractionated course, in other words, 2 treatments separated by a few hours, seems to be what they feel is a better way of delivering the treatment if you're doing it after someone's had external beam radiotherapy. So yeah, they'll be asking you lots of questions in the months and years to come about side effects and toxicity and that kind of thing as they build up a database of saying, yes, it's a safe thing to do after external beam radiotherapy, and yes, hopefully you've gone back into remission.
So this is part of a trial, is it?
I don't think it's a trial. I think it's just more of a prospective data collection, but you'll have to talk to Peter Hoskins about that. I'm sure he would explain it for you.
Okay, thank you.
Good luck.
Thank you.
Charles Kemp.
Yes, thank you for that. It was very interesting. I just want to check if I've really understood this. I've had the hormone treatment, I'm still on the hormone treatment, and I've had radiotherapy. I seem to have thought that brachytherapy is something you have before radiotherapy, or you have it instead of radiotherapy. So is this something that, depending on the circumstances, would apply to me, or have I gone past the time where I could have brachytherapy?
Well, just to make it really confusing, there are all of the options you've just described. So you can either have brachytherapy on its own, or you can have high dose rate brachytherapy followed by external beam radiotherapy, or you can have external beam radiotherapy followed by high dose rate brachytherapy, or you can just have external beam radiotherapy, as was described by the last gentleman, and then years down the line, if you get a recurrence, then you can have high dose rate brachytherapy
Right.
as a treatment to try and salvage it. I think if a decision had been made that you were having hormone treatment and just external beam radiotherapy, then hopefully the decision is that that's sufficient treatment and you've gone into remission, and that's the end of it. So the choice of the treatments, we didn't really talk about the patient group that we do it for. The choice of the treatments depends really on the risk factors of the cancer at the time of diagnosis. And rather than talking about individual patients, I'll just give you a broad overview that in the patients where I showed you those MRI scans of the patient where it had gone up into the seminal vesicles, that's called a T3B tumor. So it's slightly more advanced than just being in the prostate. Also, the slightly higher grade cancers. So if it's a grade 8, 9, or 10, then that's a higher grade range. Then those are the patients which would often be thought about for the brachy boost. And then there's also the patients with a slightly higher PSA. So if the PSA is 30, 40, maybe even higher at the time of diagnosis, then that would also be a possible rationale for giving it. But there's also other factors you've got to think about when you're considering whether it's the right thing to do, and that is urinary symptoms, because it can aggravate urinary symptoms. And if people have got not insignificant symptoms already, then brachy may not be the best option for them. Also, if they've got other medical problems, other comorbidities, as we like to call them, which are going to make the anesthetic a bit more challenging, or whether people are on blood thinning treatment, which is not quite so good if you're going to start sticking needles into them, then all of these things come into play. So there is a broad group that we do down in Sussex, which is the high-risk localized group. But again, they've got to have pretty few urinary symptoms and hopefully be otherwise pretty fit and well.
So in my case, probably then is, if everything stays okay at the end of this last year of hormone therapy, I'm okay. If something else happens, then brachytherapy might be a possibility.
Possibly. It would be very hard for me to comment on your individual.
Yeah, thank you. Thank you.
That's all right. So there are no other hands up at the moment that I can see. Roger, have you had a presentation at any stage relatively recently about the Radicals trial?
No, we've not had anything on radicals. No.
Can I show you some slides on radicals then? Because I think it's probably more interesting and relevant than the other presentation that I was thinking about.
Yep. Okay.
So I'll do that one if that's okay, if I've got time.
Yep.
Now let's see if I can get it working again. So let's get rid of the participants in the nicest possible way. Share screen.